Proper management of acute hypertension is imperative in order to prevent end organ damage. A conservative approach to initiation of therapy or a too rapid reduction of critically elevated blood pressure can lead to serious complications such as encephalopathy or ischemia. In order to understand the treatment of acute hypertension, it's vital to review the hemodynamic equation, in which blood pressure equals cardiac output times the systemic vascular resistance. Cardiac output is a product of stroke volume times heart rate. The stroke volume is determined by the end diastolic volume minus end systolic volume. Any factor that alters end diastolic volume will change the stroke volume and therefore the cardiac output. Finally, the end diastolic volume, or preload, is determined by the amount of venous return plus the end systolic volume. Various IV antihypertensive agents affect different parts of the equation, reducing blood pressure by lowering cardiac output, systemic vascular resistance, or both. Here, we'll focus on 4 classes of IV antihypertensives: beta blockers, alpha beta blockers, nitrates, and calcium channel blockers. First, the beta blockers. Beta blockers such as esmolol block beta-1 receptors located on cardiac muscle that directly affect heart rate. Although reducing the heart rate can reduce blood pressure, for those patients who are normocardic or bradycardic, this type of therapy may not be the best choice. Blood pressure can also be reduced by decreasing afterload, preload, or both. For example, alpha-beta blockers like labetalol reduce afterload through arteriolar dilation, but also cause a reduction in venous resistance, therefore decreasing preload, stroke volume, and cardiac output. Nitric oxide donors such as sodium nitroprusside also cause reductions in both preload and afterload. These non-specific nitric oxide donors dilate vessels on both the arterial and venous sides of the circulatory system. This reduces afterload by a reduction of systemic vascular resistance. But it also reduces preload due to decreased venous return, which reduces stroke volume. The organic nitrates, such as nitroglycerin, dilate primarily the venous side of the circulation, reducing preload and thereby causing a reduction in cardiac output. As agents that reduce preload are given, care must be taken to monitor cardiac index to judge whether an ionotrope should be added. Now let's look at the effects of Cardene IV. As you know, systemic vascular resistance is one of the primary causes of acute hypertension. Cardene is a dihydropyridine calcium channel blocker, available in both IV and oral formulations, which binds specifically to L-type calcium channel receptors located on arteriolar smooth muscle. This causes the arterial vasculature to dilate, which reduces blood pressure through selective reduction in afterload. This makes Cardene IV a pure arteriolar dilator. Finding the right antihypertensive agent for your patients is one of the most important choices you can make. Different antihypertensive agents affect different parts of the hemodynamic equation, so it's vital when choosing an agent to consider the overall effect. Cardene IV reduces systemic vascular resistance, the underlying cause of hypertension in most critically ill patients. The result: effective management of hypertension with tight and targeted control.